Hey everyone, welcome back, or if you're just joining us, welcome to KSSP Podcast. I'm Spencer.
And I'm Katie. Today we're going to be talking about opioids and opiates. So just to clarify, I'm going to start off here. According to the CDC, opiates refer to natural opioids such as heroin, morphine, and codeine, while the term opioids refers to all natural, semi-synthetic, and synthetic opioids. So we're going to look at this image here. The source is adapted from Hugh Guinea, Wikimedia Commons, from Ian Hayden and staff. So this is opioids do more than stimulate the brain pleasure center. Neuroscientists are still learning where drugs like heroin and fentanyl target and how repeated exposure to them reshapes the brain. So here's what we know so far. The prefrontal cortex and the central reward pathway. There is a natural link between pleasure and complex thoughts, such as decision-making and planning. With long-term opioid abuse, the pathway becomes dysregulated. And then the amygdala in the midbrain. The urge to keep using opioids is born here. The midbrain helps steer behavior based on what it has experienced. And then the locus coeruleus and the brainstem. So opioids can suppress the brainstem's ability to control breathing and heart rate. During overdose, this can kill the user. So, typical routes of administration. It's really going to depend on what you're using specifically. But all in all, they can be oral, such as swallowing a pill. You can snort, smoking, and injecting. So that's typically how people use opioids and opiates.
And then we're gonna move again into the pharmacology here. So, opioids bind to specific opioid receptors in the nervous system and other tissues. There are three principal classes of opioid receptors: mu, kappa, and delta, although up to 17 have been reported and include the epsilon, iota, lambda, and zeta receptors. There are three subtypes of mu receptor: mu1, mu2, and the newly discovered mu3. Opioid receptor like receptor 1, ORL1, which is involved in pain responses as well as having a major role in the development of tolerance to mu-opioid agonists used as analgesics. G-protein coupled receptors act on G-protein coupled receptors acting on GABAergic neurotransmission. So, response to an opioid depends upon the receptor to which it binds, its affinity for that receptor, and whether the opioid is an agonist or an antagonist. Each group of opioid receptors elicits a distinct set of neurological responses, but the receptor subtypes, such as mu1 and mu2, for example, provide an even more specific responses. Unique to each opioid is its distinct binding affinity to the various classes of opioid receptors. It is this combinatorial mechanism that allows for such a wide class of opioids and molecular designs to exist, each with its own unique effect profile. Their individual molecular structure is also responsible for their different duration of action, whereby metabolic breakdown is responsible for opioid metabolism. And then we just have a little article here from the NIH, how opioid drugs activate receptors. So, at a glance, researchers found that opioid drugs and the brain's natural opioids differ in how they activate receptors in nerve cells. And this difference may help researchers develop better treatments that are less addictive than currently available opioid drugs. So opioids work by activating opioid receptors on nerve cells, and as mentioned, they belong to a family of proteins known as G protein-coupled receptors. And recent studies have found that those G protein-coupled receptors that can be activated within the cell, as well as at the cell surface. And a research team set out to test whether all opioids, whether endogenous or not, bind to the same receptors in nerve cells. They designed a tiny sensor called a nanobody that generates a fluorescent signal when an opioid receptor is activated. They used that nanobody to detect endogenous opioid activating receptors on the surface of a nerve cell. And they found that activation by the endogenous opioid wasn't restricted to the cell surface. Receptor molecules entered the cell inside what is known as an endosome. There, they remained activated for several minutes. In addition to activating receptors on the nerve cell surface and in endosomes, opioid drugs had a different wave of activity. Within tens of seconds, they induced nanobody signaling in receptors in internal structures known as the Golgi apparatus and Golgi outposts. The different and more rapid ways that opioid drugs interact with these receptors may help explain their undesired side effects. And these findings could help guide the design of pain relievers that don't have these unwanted effects.
All right, now we're just going to go over a couple things here. So, possible side effects of opioids include drowsiness or sedation, dizziness, nausea and vomiting, constipation, physical dependence, and dependence often manifests itself with withdrawal symptoms where opioids are discontinued or decreased. And then tolerance. As you take repeated doses of opioids, you require increased medication or drug dosage to experience the same effect of pain relief. And respiratory depression. This can occur in healthy people, especially with high doses. However, people with COPD, asthma, or other lung conditions may be even more susceptible to fatal respiratory impairment. And then we have some more here from heroin drug facts from the NIH. And then, let's see. So heroin enters the brain rapidly and binds to opioid receptors on cells located in many areas, especially those involved in feelings of pain and pleasure and in controlling heart rate, sleeping, and breathing. Let's see. And then the more short-term effects. People who use heroin report feeling a rush, which is a surge of pleasure or euphoria. And however, there are other common effects, and these include dry mouth, warm flushing of the skin, heavy feeling in the arms and legs, nausea and vomiting, severe itching, clouded mental functioning. They call it going on the nod. I've never heard someone on the street call it on the nod. Usually they call it nodding off. But anyways, so nodding off, which is a back and forth state of being conscious and semi-conscious. And I'm going to talk more about that in our conclusion as well. And then the long-term effects. People who use heroin over the long term may develop insomnia, collapsed veins. It says for people who inject the drug, but I mean, even people who just don't inject the drug can still have the collapsed veins. And then there's damaged tissue inside the nose of people who sniff or snort it, infection of the heart lining and valves, abscesses or swollen tissue filled with pus. That's usually from injections that go wrong. And then there's constipation and stomach cramping, liver and kidney disease, lung complications including pneumonia, mental disorders such as depression and antisocial personality disorder, and sexual dysfunction for men, and, well, I think there's sexual dysfunction for women as well. And then irregular menstrual cycles for women. And then we'll just talk about how the addiction is treated really quickly, the drugs that they use for opioid use disorders. These medications are safe, effective, and save lives. They interact with the same opioid receptors in the brain on which heroin acts, but they do not produce the same effects. So we have methadone, which is the opioid receptor full agonist. It attaches to and activates opioid receptors to ease withdrawal symptoms and cravings. And then there's buprenorphine, or Suboxone as it's also known. And that is an opioid receptor partial agonist. So it attaches to and partially activates opioid receptors to ease withdrawal symptoms and cravings. And finally, we have naltrexone, which is an opioid receptor antagonist. And it prevents heroin from attaching to opioid receptors, and it will block its effects. But you should not use alcohol or opiates if you are taking naltrexone, because it can have really, really severe side effects if you do. So let's see. They come from opioids are made from morphine, which is a natural substance taken from the seed pod of various opium poppy plants. So heroin enters the brain rapidly and binds to opioid receptors on cells located in many areas, especially those involved in feelings of pain and pleasure and controlling heart rate, sleeping, and breathing. And then misuse of prescription opioid pain medication is a risk factor for starting heroin use. And then naloxone is the medicine that we give to treat a heroin overdose. More than one dose may be needed. And heroin can lead to addiction. Yeah, so that was that article.
And then I just have a few things here on opioid addiction, just because I was interested in what they, like the pharmacology, I guess, kind of. So, when opioid drugs infiltrate a part of the brain stem called the locus coeruleus, their receptors slow respiration, cause constipation, lower blood pressure, and decrease alertness, as we have talked about. And addiction begins in the midbrain, where opioid receptors switch off a batch of nerve cells called GABAergic neurons. Once opioids shut off GABAergic neurons, the pleasure circuits fill with another neurotransmitter called dopamine. At one stop on this pleasure highway, the nucleus accumbens, dopamine triggers a surge of happiness. And when dopamine rolls into the amygdala, that's the brain's fear center, as we have talked about, it ends up relieving anxiety and stress. Both of these events reinforce the idea that opioids are rewarding. And in a 2017 study, it found that most patients, 81%, whose addiction started with a chronic pain problem, also had a mental health disorder. And another study found patients on morphine experience 40% less pain relief from the drug if they have a mood disorder. And then replacement medications stick to the receptors for... Oh, so I think they're saying this is why, like, those medications that can be used, the ones that you just mentioned, is because they stick to receptors for longer periods of time, which can help curtail those withdrawal symptoms. And then I guess it was mentioned that opioid replacement therapy does not work for fentanyl, because I think it's a different, like, it does a different, because it's like a synthetic, isn't it?
Yeah.
So it's like a different mechanism.
Okay. Wait, so this is more, what you discussed was more about opiates, like heroin and morphine, than about fentanyl, synthetics like fentanyl.
Yeah, I think so, yeah.
Okay. Got it. Interesting. Well, that's our episode on opioids and opiates. So next time, in our next episode, we're going to be talking about PCP, the final drug we're going to go over. So you can join us for that episode.
And as always, you can leave a comment below if you have topic ideas that you want to hear us talk about in future episodes.
You can reach out to us on Facebook, YouTube, Instagram, Twitter, and TikTok. We also occasionally Twitch live stream, so you can follow us there. It will be notified when we do.
And don't forget to give the video a like, as well as follow or subscribe to our other social media accounts and turn on notifications so that you get notified when our content comes out. Otherwise, we will see you all in the next video.